What disorders are related to cystine? There are two disorders that exhibit renal manifestation, cystinuria and cystinosis. Cystinuria is the defect in the renal tubular transport of amino acid. Cystinosis, on the other hand, is an inborn error of metabolism. Cystinuria is inherited and is marked by elevated amounts of amino acid cystine in the urine. There is inability of the renal tubules to reabsorb cystine filtered by the glomerulus. There are two modes of inheritance. The first one affects the reabsorption of all four amino acids, where 65% of people with this kind of condition forms renal calculi early in life. And the second one affects only the reabsorption of cystine and lysine. Cystinuria is grouped into three classifications, and this grouping is based on the two inherited genes and their heterozygous and homozygous inheritance. Any form of inheritance predisposes an individual to form renal calculi, but this is less commonly seen in individuals with inheritance that only affects their absorption of lysine and cystine. Because cystine is less soluble than the other three amino acids, laboratory determinations are based on observation of cystine crystals in the sediment of concentrated and or first morning specimens. Also, cystine is the only amino acid found during the calculi analysis from these patients. Cyanide nitroprusside test is the test used for testing cystine, and is based on the reduction of cystine by sodium cyanide and by the addition of nitroprusside. Cystine in the urine specimen will produce a red-purple color. However, ketones and homocysteine also produce false positive reaction. Therefore, additional testing is done using ion exchange chromatographic quantitative analysis of a 24-hour urine specimen. The other cystine disorder is cystinosis and is considered a true inborn error of metabolism, and it occurs in three variations ranging from fatal disorder developed in infancy to a benign form appearing in adulthood. Cystinosis is a defect in the lysosomal membrane which prevents the release of cystine into the cytoplasm for metabolism. Therefore, cystine is not completely metabolized and leads to crystalline deposits of cystine in many areas of the body, including the cornea, the bone marrow, lymph nodes, and internal organs. Cystine deposits in the proximal convoluted tubule affects and interferes with the absorption, and this is different from the inherited disorder of renal tubular reabsorption as seen in cystinuria. Continued deposition of cystine, if left untreated, will result to renal failure early in life. Cystinosis is divided into two categories, nephropathic and non-nephropathic. Nephropathic has two groups, the infantile and late-onset cystinosis. Infantile nephropathic cystinosis shows rapid progression to renal failure, while late-onset cystinosis has a gradual progression to total renal failure. Non-nephropathic cystinosis is benign but may cause ocular disorders. Diagnosis of infantile nephropathic cystinosis is done by molecular genetic testing.